everyone. Thank you for joining us today for the next episode in our COVID-19 Healthcare Digest series. The Mazars Healthcare Consulting Group began presenting this short video series in March as a resource to the healthcare industry because of the rapidly changing guidelines and strategies related to the public health emergency. Today, we are presenting episode 9, Prevention, Flu Immunization in the Era of COVID-19. My name is Kathy Neal. I am a doctoral prepared registered nurse and director at Mazars. I will be joined by my colleague, Udi Burnett, who is also a registered nurse and director at Mazars. Before we get started, a brief disclaimer. The information we are providing today is effective as of September 1st, 2020. As most of you listening know, information around COVID-19 changes rapidly, in some cases several times a day. This new information may impact your flu campaigns, and we encourage you to continue to monitor for updates from the CDC. The key items covered today will be the current status of the public health emergency, the identified care gaps and current recommendations related to preventive screenings and immunization, and finally, some best practices related to influenza planning this year. American life has fundamentally changed as a result of the COVID-19 virus, which caused a public health emergency to be declared January 31st, 2020. Since then, concerts, parades, baseball games have continued to be canceled. Countless people have found themselves jobless, uninsured, and struggling to afford housing and food. Many schools and colleges will hold few or no in-person classes this fall. The virus has left no state unscathed, but its impact has been wildly uneven. 3 states, California, Florida, and Texas, have collectively had about a third of all cases in the United States. Unlike the early days of the public health emergency, it is not so simple to say that big cities have been hit the hardest. On a per capita basis, many of the places with the most cases have been small and mid-sized metros in the Southwest and large Native American or Hispanic populations. In Yuma, Arizona, which is along the border of Mexico, 1 in 18 residents have had the virus. And in McKinley County, New Mexico, which includes part of the hard-hit Navajo Nation, nearly 1 in 300 residents has died from the virus. As of September 1st, the global incidence is more than 25.5 million cases and over 851,000 deaths. The U.S. has had more than 6 million cases across every state, which includes Washington, D.C. and the 4 U.S. territories, and nearly 184,000 deaths. Overall, the number of cases in the U.S. are currently decreasing. However, hotspots continue to be identified in the states not previously identified as hotspots. We see the same trend with other countries, including surges after a period of decrease and supposed relaxing of infection control practices such as social distancing. Issues with hospital capacity have varied as the cases increased and decreased. While hospital capacity has been tracked through ICU capacity, long length of stay related to skilled nursing facilities not willing to accept COVID patients, and not getting the short-term rehab patients due to cancellation of elective surgery was not measured or reported outside of healthcare circles. We're going to hear momentarily what the impact has been to preventive services across the U.S. At this time, the best advice we can offer is to use the rate of community transmission to guide decisions to reach out to patients for preventive care, which includes flu immunization as we enter the flu season this fall. So what is the rate of community transition? The COVID Tracking Project has been collecting data across 50 states and 5 territories and the District of Columbia since March to provide a data set that is used by national and local news organizations, research projects, and agencies worldwide. This data is reported as the virus reproduction number, or simply rate of transmission. If the rate is above 1.0, the virus is spreading more quickly, and conversely, when the rate is below 1.0, the virus spread is reducing. This slide is a snapshot of the rate of COVID-19 spread on August 31st, 2020. The rate changes daily, and it's hard to draw specific conclusions from a daily snapshot. However, over time, we do see some stabilization of the rate of COVID, but not elimination at this point. So what does that mean? It means the spread of COVID-19 appears to continue to be flattening in most states, but increasing in a handful of states. It should be noted that after every holiday, there has been a surge around the country. With Labor Day fast approaching, we might expect there to be some additional changes to the rate of spread as a result of celebrations resulted to what many consider to be the last weekend in summer. And now my colleague, Udi Burness, will be discussing preventive care gaps and best practices.
As we all know, there are various preventive measures depending on the population that you're serving. The most common measures are those required for HEDIS or MIPS. The most common measures fall into the buckets listed above, which include cancer screening for colorectal, breast, cervical, and lung cancer, immunizations to help prevent disease, flu and pneumonia vaccinations, and screening and counseling service for various things like alcohol use, depression, weight loss, diabetes, sexually transmitted disease, tobacco use, and fall and risk prevention. HEDIS and MIPS are only reported annually, so it will be some time before we see the full impact on preventive services due to the COVID pandemic. This chart shows that the preventative cancer screenings in the United States abruptly dropped 86% for colon, 94% for breast and cervical cancer screening following the declaration of the COVID national emergency. The number of cancer screenings has recently begun to rise, but has not yet reached previously expected levels. June 16 weekly volumes remain 29%, 36%, and 35% lower than their pre-COVID-19 levels for breast, colon, and cervical cancer screenings. The gap between the expected screenings and the actual screenings created a sizable deficit of missed screenings. Between March 15th and June 16, 285,000 for breast, 95,000 for colon, and 40,000 cervical cancer screenings were missed, which represents a deficit of 63, 64, 67% relative to the number of screenings that would be expected based on their historical averages. As you can see from these gaps, recent EHR data from the EPIC research group shows that immunization administration for pediatric patients has decreased by 42% in the spring of 2020 compared to previous years. It is estimated that 260,000 immunizations expected from March 8th through May 9th were missed or delayed across all age groups at sampled organization. Patients under the age of 6 months showed the smallest reduction in immunization volume, but these patients still missed or delayed an estimated 29,000 immunizations this spring. The number of immunizations that have dropped is very concerning because children are not getting their necessary immunizations. If this trend continues, then our children will not be immunized and have the potential for diseases that we once eradicated. This graph shows that the number of missed immunizations between March 13th through May 9th. As you can see, in each age group, the number there are significant numbers for children that did not receive their immunizations. Immunizations for these young patients are beginning to return toward the average, but this does not mean that the pediatric patients are caught up on their vaccination schedules yet. This is particularly concerning for infants since most of the protection from maternal antibodies is gone by 6 months. There is typically a spike in pediatric immunization volume from mid-July through August as patients get required immunizations for the school year. This year, patients catching up on missed immunizations may result in higher demand for immunizations during the summer months. However, it is also possible that patients will be slow to return the clinic as states gradually reopen. This data raises concerns that pediatric patients may be missing or delaying immunizations that play an important role in preventive care, not only for individual patients, but also for an overall herd immunity. It is imperative that we get patients to come in and get their preventive services. The CDC has come out with their recommendations for best practice for monitoring preventative services. There are various considerations to think about. One is implement telehealth strategy for patients with chronic diseases and reassure them that it is safe to get their necessary preventive services. Separating sick patients from well patients in separate areas of the office. I know of several medical groups that have their sick patients access a different entrance than their well patients. They are also scheduling their well visits at different times than their sick visits. Take patients immediately to an exam room instead of letting them sit in the waiting room. Some locations are actually having the patients wait out in their car before they come in. Control access by limiting access to the facility. Consider nurse triage protocols. Educate the patients about the need to wear a mask to their visit. Waive cancellation fees if patients are canceling their appointments due to illness. And have the patients wait in their car. There are many approaches to getting patients to get their preventive care services. Kathy will now talk about influenza planning for this flu season.
Thank you, Udi. Well, if there's any good news, it's that the Southern Hemisphere, whose flu season runs April to September, is reporting low numbers of flu this year. Experts think this may be related to the COVID-19 control measures. However, the impact of COVID related to the avoidance of preventive services, the health facilities, work from home limitations, and the newly uninsured have left public health officials concerned about the possible impact on our healthcare capacity and system if there is an explosion of COVID-19 and flu cases at the same time this winter. The CDC is calling this a worst-case scenario and likely one of the most difficult times that the American health system will ever experience. We know that reducing flu cases is directly related to the incidence of immunization in the public. There is concern about how many Americans will seek out their flu shots this fall, as many are already avoiding healthcare settings during the pandemic, and many who received the flu shot at their employers' offices are now unemployed or working from home. Last year, only about 47% of Americans got a flu shot. This year, the CDC's aggressive goal has been set at 65% compliance. The CDC is recommending focus on vaccinating the high-risk groups first, those that are 65, have chronic diseases including asthma, COPD, cardiovascular disease, diabetes, and obesity, those who are immunocompromised by cancer, HIV/AIDS, children with neurological conditions, pregnant women, and the very young children. Education of the community and patients is going to be vital to achieving this immunization rate that the CDC has targeted. There is a lot of misinformation in social media regarding flu vaccinations at this time. The optimal timing of the immunization is mid-September to the end of October, which ensures potency through the end of the flu season. Administering the immunization too early may leave patients exposed at the end of the season. Practices might consider national trending when deciding the best time for immunization in their practices. For example, the West Coast is typically infected earlier than the East Coast with the flu. Both COVID-19 and the flu are caused by viruses, but they are not the same virus. COVID-19 is caused by the coronavirus, and the flu is caused by the influenza virus. There will be a need to minimize chances for exposure to COVID-19 when thinking about the flu vaccine program. To reduce exposure to COVID, practices will need to screen all patients for COVID symptoms, limit and monitor entry points into the facility, which may mean installation of barriers and/or added security, as well as implementation and aggressive monitoring of policies related to cloth face masks, covering of all patients over 2 years of age, and good hand hygiene. While it's difficult to distinguish the flu from other viral or bacterial respiratory illnesses, including COVID-19, based on symptoms alone, it is recognized that both the flu and COVID-19 have symptoms of fever, cough, runny, stuffy nose, body aches, headache, and fatigue. The difference is that COVID-19 symptoms may take longer to develop, and the loss of taste and smell is unique to COVID-19. We know that vaccination is the most effective way to prevent infection and reduce the rate of severe outcomes caused by the influenza virus. But the constantly evolving nature of the influenza viruses requires continuous global monitoring and frequent reformulation of the influenza vaccine. The World Health Organization convenes technical consultations in February and September each year to recommend viruses for inclusion in seasonal influenza vaccines for the northern and southern hemispheres, respectively. These recommendations are based on information provided by the WHO Global Influenza Surveillance and Response System. Since 2004, influenza A and other subtypes of influenza viruses have also been taken into consideration for pandemic preparedness purposes. The CDC recommends annual influenza vaccination for everyone 6 months and older with any licensed influenza vaccine that is appropriate for the recipient's age and health status. And the CDC has no preference expressed for any one vaccine over another. This year, there are 2 trivalent vaccines and 7 quadrivalent vaccines, including a live attenuated nasal spray. Children between 6 months and 8 years of age who are getting their first ever flu vaccine will need 2 immunizations at least 4 weeks apart for the best coverage. And not to be forgotten, this is a perfect time to check seniors for pneumococcal vaccines, either the Prevnar 13 or Pneumovax 23. Proper vaccine storage, preparation, and handling are critical in maintaining the integrity of the vaccine. Always follow the manufacturer's recommendation. In determining whether to use multi-dose versus single-dose immunization, you'll need to consider both the quantity of immunization and staff time needed to use multi-dose vials. There are stories every year of clinics not storing vaccinations properly, requiring notification of the patients, and in some cases, re-immunization. The CDC recommends use of purpose-built biological, pharmaceutical, or medical-grade storage units, or standalone refrigerator and standalone freezer units suitable for vaccine storage rather than a combination refrigerator-freezer or other units not designed for storing fragile biologics such as vaccines. Staff can easily become confused about vaccines within the storage unit because there are so many brands and formulations available. It is important not to overcrowd the storage unit and to maintain the appropriate temperature range. Labeling the area or separate boxes where vaccines are stored can help staff quickly locate and choose the correct vaccine. Rotating stock will prevent wasted product that might expire if not used timely. And finally, it's important to plan for the annual competency needed by staff who will be handling and administering the vaccine. There are many ways to demonstrate competency, including clinic-driven testing. We've provided a link above to the CDC training that includes one contact education hour for successfully completing the program. As we noted earlier, the local level of COVID-19 spread should guide decisions related to how to administer your flu immunization program. Because of COVID-19, it is necessary to consider your supply of personal protective equipment. Not only gowns, masks, and gloves, but this year, eye protection is recommended in areas with moderate to substantial community transmission of the virus. For areas with minimal to no community transmission, eye protection would be considered optional. As healthcare providers, we cannot stress enough the importance of hand washing for both patients and caregivers. Use of gloves need to be augmented with sanitizing gel or hand washing when hands become contaminated during the immunization clinic. Screening and triaging of all patients upon entry will be necessary to prevent any active COVID-19 cases from possibly infecting the well-flu immunization population. Flu immunizations are not recommended for patients who are symptomatic with COVID-19 until those patients are asymptomatic. And of course, consider how patients will social distance when standing in lines to get immunization. Now, let's take a look at some best practices. The best practices focus on infection control processes of social distancing, avoiding crowds, masks and eye covering, and hand hygiene. So consider scheduling clinic visits so that all sick visits occur at one time of day. All well care visits then occur at a different time of day. Consider clinic redesign to use the space more effectively. Separate well visits from sick visits. Consider hubs for vaccines in larger rooms. You might consider the use of tents in the parking lot instead of conference rooms, entranceways, or hallways. Schedule high-risk members first and separately, including children. Remember, high-risk members are older adults and persons with underlying chronic conditions. Consider the use of standing orders to improve efficiency of vaccination administration. Standing orders authorize nurses, pharmacists, and other appropriately trained healthcare personnel, where allowed by state law, to assess a patient's immunization status and administer vaccination according to a protocol approved by a medical director in a healthcare setting, a physician, or another authorized practitioner. Standing orders work by enabling assessment and vaccination of the patient without the need for clinician examination or direct order from the attending provider at the time of the interaction. Sample standing orders can be found on the Immunization Action Coalition website at www.immunize.org. Consider the reduction in reuse of clipboards and pens by using electronic communications as much as possible for a means of registration. As an added benefit, using electronic registration will also minimize the time in the office. Think about the existing care gaps you have. Thinking about the existing care gaps, you have the opportunity to consider other screenings that can be done at home with high-risk patients, such as colorectal screening, blood pressure screening, hemoglobin A1Cs, depression screening, etc. Partner with health plans, hospitals, public health departments on options for immunization. Think about pharmacies, dialysis clinics, skilled nursing facilities and long-term care, home health, home visits, and even mobile clinics as opportunities. Brainstorm with your clinical teams about social distancing options. For example, pharmacies are implementing social distancing precautions through tents in the parking lot, administering vaccines curbside, or requiring appointments to manage the volumes. Other options include drive-through clinics similar to the COVID testing sites. We are seeing county fairgrounds being used for community testing as all the county fairs have been canceled in California. Is there an opportunity for other agencies, large clinics, many smaller clinics partnering to accomplish high rates of immunization this year using those same sites? Occupational health opportunities exist for employers. The use of tents outside versus conference rooms and smaller events occurring over shorter periods of time, but more days. Employers can consider health fairs with immunizations if social distancing can be maintained. A final resource we recommend is to frequently check the CDC's interim guidance for immunization services during the COVID-19 pandemic at the cdc.gov website. The next two slides are some resources that might provide assistance to you as you plan your flu campaign this year. It's been our pleasure to present on flu immunization planning this year. We thank you for your efforts to immunize and educate your patients, family, and staff regarding the importance of preventive services and vaccination, especially during the era of COVID-19. Our contact information is included on the last slide for any questions or comments.